Good evening. I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island and the tri-state community. We have a wonderful guest, someone we've had before, and we've had multiple people wanting him on again. He's probably one of the most popular guests we've had over the 10 years that we've been here. I want to thank community media for having us, our show on. I want to thank David Marcus, our producer. Sal and Helene are back there putting us all together. I really want to thank them from the bottom of my heart for the 10 plus years that we've been with you. And I also thank the community as a whole for welcoming us and welcoming the show into your homes. We're going to talk about pediatric surgery. So you think about what a pediatrician does, what a surgeon does, and you put them together because it sort of brings together much of what people go into medicine for. So I have the preeminent pediatric surgeon almost throughout the area. It is Brian Gilchrist. He's at Richmond University Medical Center, where I'm chief of neurology. He works in the pediatric surgery department. And we're going to sort of bring an idea of what surgery means to the population, what pediatric surgery is, and some questions I've asked as I have years ago. First of all, maybe we'll start out with what's a pediatric surgeon? Is it a pediatrician? Is it a surgeon? How do you put it together?
Well, when you take all the surgical subspecialties, I think probably the pediatric surgeons are the nicest group. We're more like pediatricians than we are surgeons in our persona. So I think pediatric surgery speaks to a gentility and to a gentleness that you don't often see in some of the other.
So tell us what, obviously it's because you're dealing with the parents, the difficulty with a child who's sick and how it affects us, but tell me why you think that.
Well, it's interesting in that usually it's a one-parent profession. You hardly ever see the fathers. The fathers are generally working or they're not present. The mothers are always there, and nobody will ever love you like your mother. And these women are very needy and very anxious when their babies or their children are sick. So it's a specialty that I think speaks to a certain magnanimity of spirit. You've got to be able to be in touch with the anxiety that these folks are feeling. Pediatric surgery training is the longest of all the subspecialties because we do general surgery first and then we train in pediatric surgery afterwards.
How many years is that?
Well, it's really 9 for most of us because you've got to do 2 years of transplant, 5 of general surgery, and 2 of pediatric surgery. So it's very involved. And, we always tell people, what are the 3 hardest things to do in America? Pass your CPA exam on the first try, get into dermatology, and get into pediatric surgery. There's only 450 of us. So, I wanted to be a Yankee. I wanted to play professional baseball and be an elite ball player. Well, I ended up doing elite surgery, so I get to operate on the kids.
What position did you want to play?
I played second base in high school and college, but it was the love of my life. But pediatric surgery is it keeps you young because you're around all these young kids.
That's so interesting. So let's talk about it. I think I've once asked this question, but I'll say it to you again. Is doing pediatric surgery like taking an adult and shrinking them down, or is it intrinsically different? And do these kids have different disorders, different things that you have to look for?
Sure. Intrinsically, a child, especially a baby, is made out of water. As you age, you have less and less water in your tissues. These kids are 90% water. So the technical aspects of pediatric surgery are a magnitude more difficult than adult surgery. So no, it's not like shrinking down an adult. It's a totally different mindset, and it's a totally different technical exercise. And we see diseases that you're born with, not that you acquire. If you get peptic ulcer disease, you get heart disease, you get varicose veins, those are acquired diseases that adults get. The kids are never, they're just victims. They all of a sudden have a choledochal cyst.
Put it into regular English.
Well, maybe they have a dilated common duct, which is part of your bile system, or they have a tumor that was there from birth, or they have a testicle that's in the wrong place, or, for instance, at Rumsey this past week, we had a baby with all his intestines born outside of his abdomen. So those are diseases that you don't see in the adult realm, but you see in children.
So tell me about your team. So anesthesia, obviously, the people put the babies or children to sleep in order for you to do the surgery. The nurses, are they specializing in pediatrics? Are they different than the adult group? And again, what training do they go through?
Let me speak to the nurses first. The nurses who go into pediatric care, and you know this, certainly in pediatric surgery, they're like angels. And over at Rumsey, they still have that Catholic ambiance. There's a warmth and a love in that hospital that's very palpable. And the nurses at our place, they are like angels. And do they have specialized training? Yes. They've been doing this for years. On the third floor over at Rumsey, some of those nurses have been there for 25 years. So they're trained both by assertion and by training. Terrific people. Anesthesia, of course, is the trickiest part of all. To get good results in any surgery, but particularly with the kids, you need superb anesthesia. And luckily, we have 3 superb pediatric anesthesiologists. So no matter what day or night it is, you have pediatric anesthesia at Rumsey. And these guys, there's one woman, Dr. Rizzo, who's from Yale. She's superb. And the other 2 fellows are just absolutely expert. One of the senior pediatric anesthesiologists, Dr. Bonenberger, he retired last year. But we filled the gap with 2 other people who are just simply superb. So I tell mothers and fathers all the time, the most important part of these operations is the anesthesia. I mean, the technical part will get you through, but the tricky part is anesthesia, and we're as good as there is in America.
So tell us and you mentioned that these are things that the children have more than they get. Acquired means like we've had years of eating and years of standing on our feet and all the things that happen to people.
That's right.
With kids, a lot of it, and we'll talk about 2 different parts. One is there are acquired things such as trauma. And the other is really what kind of things are, and you use all these fancy words about cysts and things. Tell us a little bit
I'll
about
keep
what
it simple for you. Yeah. The things that are truly inherited, for instance, are like hernias. Just a simple hernia where all of a sudden the bowel is going down into your scrotum or down into the labia in a girl. And these things have to be fixed. Kids are born with these deficiencies.
And it happens why? Because the ligaments that would protect us from going from one space to the other. What does the word hernia mean? Maybe that's a good thing.
The way to think about a hernia is this way. You should have a membrane that separates your upper abdomen from your lower abdomen. In some people, they don't have that. So they have a sleeve like your jacket through which things travel down into the lower regions. That's a hernia. That's as simple as it gets. But they have to be fixed, because if they're not fixed, the bowel gets stuck down there or the testicle doesn't get enough blood supply. And to go even further, there's kids who are born with undescended testicles, where the testicles are up in the abdomen or in the canal. Those have to be brought down. If you don't bring them down, the children will end up either with a tumor or with a torsion, where it twists, and then you have tremendous pain and sometimes a dead testicle. These have to be fixed, and these are all congenital anomalies.
Are they fixable?
They're all fixable. They're all fixable.
Even with regard to, you mentioned a testicle torsion, and you talked about, what about fertility in those kids?
So that's an interesting question. If you have an undescended testicle, you have to get it down into the scrotum within 24 months. You can't go beyond 2 years. The minute you go beyond 2 years of age, they have a decrease in spermatogenesis and their fertility rates go down decidedly. So you want to get these kids, you want to wait on most children until they're 6 months of age to operate on them, because anesthesia is less complicated after 6 months. So between 6 months and 24 months, you want to get these things fixed.
So let's go into why. It's not really intuitive. Maybe it is to you. Why are they safer for anesthesia after 6 months than the first 6 months?
Here's the interesting thing about anesthesia. Even today, 2026, people don't really understand the mechanism of what puts you to sleep. I mean, the brain is still, you're a famous neurologist. You know all this stuff. People just still don't understand how it is that all of a sudden you're asleep and how all of a sudden you wake up. So, but we do know this, that if you give anesthetics to children under 6 months of age, there can be some damage to brain cells, to neuronal connections that have to be addressed. When you have to do them emergently for like gastroschisis, where all the guts are born, you don't have any choice. You got to operate. But if you can wait till 6 months with most of these kids, you're better off.
Yes, they get bigger, a little stronger, all that part of it. So what about things like circumcisions? I mean, a lot of people have circumcisions obviously very quickly. Anesthesia is probably minimal or none. So tell us a little bit about that.
Circumcision is a very interesting discussion. It goes like this. Let me give it to you in detail.
Okay.
For 3,000 years, the Muslims and the Jewish people circumcised their kids for cultural and religious reasons. The Americans, from 1830 on, as there was a westward migration to Indiana, Ohio, surgeons from Savannah to Boston all circumcised the boys. So it became an American norm. Americans, 90% of American males are circumcised because the hygiene was poor out west. That was the underlying concept. Europe and Asia were very critical of Americans for doing circumcisions, and especially the British, who said the American surgeons were doing it for money. You get about $30 for doing it, so it was never for money. So it was for hygiene. So 10 years ago, the WHO and then the CDC showed definitively that HPV 16 and 17 and HIV live in the foreskin. So now it became an issue of public health. So now we advise everybody to have circumcision, irrespective of your background. So when I finished training at Brown, 1995, we always kept the boys the same as the fathers. We no longer do that. Now we say that everybody needs to be circumcised. That's the sort of the teaching. And you don't have to use anesthesia for the tiny kids. I use a little local, and you do it neatly, and I do it with a knife. But I watched the Moyles, who are experts at doing these, when I was at Downstate, and they don't even put in sutures. They just use a hemostatic agent and wrap the penis, and they do beautifully. So we put in 4 or 5 sutures that dissolve.
So there's nothing for mom and dad to be frightened about if they want to do a circumcision early on.
They should be, sir. You know, the other interesting thing is if you're a woman and you're with an uncircumcised male, you have a 35-fold increase in cervical cancer. So that's all these girls now and all these women who read the internet, they're not letting these teenage boys near them or older people unless they've been circumcised.
Okay. Let's move on to trauma. You said that's one of the biggest cutting issues that we see. You know, sad to say there's so many traumatic injuries, things that are happening in our streets, things that are happening to our kids, adults also, of course, falling, hurting themselves. And in my population as a neurologist, there's nothing more devastating than for a senior citizen to fall. The trauma that we have, hip fractures, the likelihood of someone not surviving a year after a hip fracture is very significant. And that's not even to talk about hitting your head or hitting other vital organs. So let's talk about trauma in pediatrics and really what the hospital is doing and what you're doing with it.
Trauma, I mean, I put guys in body bags in Iraq. You know, I did Iraq twice. And
so tell us what you do in Iraq. Tell me a little bit more.
I was a combat surgeon for adults. And I want to just say to you that if you have a child or a teenager who's been seriously injured or killed, it's devastating. There's no greater sorrow in the world than the loss of a child to a parent. There's just none. And it's something you never get over. No family, no parents ever get over it. And it brings me great sadness to see. I've been taking care of these kids for years, and the one thing I say to people, especially as the summer comes, please don't take a couple of drinks and think you're okay. You don't want to run over a kid. You don't want to pop somebody on a bike. Just, if you're going to have a couple of drinks, either stay home or get an Uber, but don't drive a car. That is one thing that I insist that people think about. The other issue, of course, is gun violence. I mean, it's a huge killer of children, accidental or on the streets. Guns are a huge issue in this country, and it's irrespective of where you stand on the Second Amendment. It's something that people, if you're going to have a gun, then make sure it is guarded and it is locked up, and children can't get at it. Our hospital is as good a trauma center as there is in America. We last year, or 2 years ago, we went through the accreditation process, and we're a level 1 trauma program. We're up again this June, on the 5th of June, I think, for the American College to come through and designate us. But I can tell you, day in and day out, our trauma bays and our trauma surgeons are as good as anybody in the country. So as far as Staten Island is concerned, they should be buoyed by the idea that they are in great hands if something bad happens. But please try to prophylax against something bad happening by being smart. Don't drink and put your guns away.
So we'll go over a little bit more details with this, but just walking through the emergency room, seeing someone come in, I've never seen anybody in more pain than people who've had a gunshot wound. You think people who have had heart attacks, stabbing, whatever it is, but just there's a certain sensation that people have when their nerves are cut, the burning sensation that people describe. You could hear from all the way across the hospital someone coming in who's been shot.
Well, when you say that, the first thing I think to myself is, I'd like to just take some of these chicken hawk politicians who send kids off to wars and come down into a trauma bay or come into a combat hospital and watch somebody who's had their leg blown off or their arm shot off and actually experience the visceral response of what happens to people. These injuries are horrible. And the pain that's inflicted, you're right, it's the bone, it's the nerve, it's the arteries, it's horrendous. And I'm telling you, if you actually experienced it, you would be so against ever sending any kid into harm's way again, ever. And I for the last 27 years, I've been taking care of these people, and it still hurts me. It rocks me sometimes.
What do you think about the TV depiction of surgeons?
I don't watch any of it.
You don't watch?
No,
you don't watch even the combat surgeons, nothing like that?
I don't watch any of it. It's all silly stuff. Listen, it's hard enough, but to go home and watch silly stuff, I'm not doing it. So I don't do it. Sorry.
So it keeps everybody.
I like Grey's Anatomy because I like the blonde, but that was the only reason I ever watched it. But I'm not watching any of that stuff. No.
Let's go back to the surgery itself. What's on the cutting edge? We talked about trauma. We talked about acquired issues. Tell us a little bit about kids, and really soup to nuts. And I'll tell you a funny story. When I was in medical school in Brooklyn at Downstate, and a surgeon, I was taking some kind of oral exam, started talking to me about skin cancers, and I said to myself for a moment, what does a surgeon have to do with skin cancer? Because again, it was always a dermatological thing. Everybody's burning off and doing things. And you don't realize how the surgeons, whether it's pediatric surgeons or general surgeons, are so involved. And obviously, from a surgical point of view, of course, it's something you have to take off, so it's a surgical procedure. If someone has a malignancy like a melanoma or basal cell, squamous cell. So tell us a little bit about just the general aspect of this, because you're seeing different things.
So you're talking about skin cancers for a second. Let me just go down that route for a second. Melanoma is a very, very scary disease. And the reason it's scary in kids, I wrote the chapter for the textbook on melanoma about 10 years ago. And I remember I went down to the NIH and I did a little research on it. The reason that it's so dangerous in kids is people don't think of it. It's always a late diagnosis, and by that point, it's deep. And melanoma spreads everywhere. And being an Irish boy with pale, pasty white skin, I'm scared to death of it myself. But it's something that everybody, regardless of your background, you've got to be very careful about the sun and melanoma. Melanoma is a killer.
But why do kids get it? So again, you talk about the sun.
Any kid can get it.
But anybody can get it, even at a very young age. So tell us, is it always from the sun?
No, it's not always from the sun, but the sun is a precipitant. And but you can get it under your toenail. You can get it on the palm of the sole of your foot. You can get it anywhere. But melanoma, if you have any nevus or any freckle, you need to have it followed. You need to be smart about this because it's an awful, awful disease. Insofar as state of the art in cutting edge, what's coming. I'll tell you a great story. The other night I was doing a laparoscopic appendectomy.
Tell everybody what that is.
I stick a scope in and take your appendix out. It's pretty straightforward. And the kid had appendicitis. And I said to the resident, I said, who wrote the first paper ever on laparoscopic appendectomy? Because I knew the answer. It was me. I wrote it in 1992. So she didn't know. And I said, well, I did, 1992. And she said, Dr. Gilchrist, I was born in 1998. So I said, that's the end of that discussion. But at that time, when we first started doing laparoscopic appendectomies, the older guys were furious with me. Especially, I gave this paper at the big meeting, and they were really angry because they did everything open. They thought it was horrible to think you could do it laparoscopically. Well, the transition was tough. But the transition from laparoscopy to now the robots has been easy because all our generation was great with laparoscopy, and now the robots are here. The robots are too big or have been too big to use on children because the ports are the area, the device you have to put in to steady the camera is size 8, and with kids you need size 2. So there was no impetus to start doing robotics in kids, but now they've miniaturized. So robotic surgery for kids is here. The future is not in the future, it's right now. So they're doing robotic. I don't know how to do robotic surgery. I have not done it myself, but I'm going to go take a course because if you don't take a course and know how to do this, you're going to be behind. But that's the future right now. Robotic surgery for kids is here.
So what would be scary to some people is to think about the surgeon not actually looking into the patient. And that's really what a lot of robotics and some of the other procedures are. You're actually looking into a view box, almost like kids playing video games in a lot of ways.
Yeah.
And How do you translate it? How do you think patients will feel or are feeling about that?
Well, I think they have to take it as an article of faith. The guys who do this, I mean, it is magnificent view. When you do you take somebody's gallbladder out. The old days, they just made an incision. Now with a robot, you see absolutely everything. In the ability to discern different parts of the anatomy, it's exquisite. You don't. It's unbelievable. So you want to say to the patients, listen, believe me, if I had to have it done, I'd have the robot do it. Because even though the guy is not opening your belly and actually looking into himself, the console through which he looks shows you everything. It's really remarkable.
Do you think that one day, let's talk about it now, are there surgeons who could do robotic surgery not even in the same room as the patient?
They're doing it in Seattle for Alaska.
Right.
So in Alaska, they set the thing up, and the guy in Seattle is doing it. I mean, it's here, and it works. You know, the interesting thing, and I say this all the time, so I'm sort of beating a dead horse. COVID changed the whole world for us. It accelerated everything. So from the internet to broadband to technology like that, because you couldn't go places. So it was coming, obviously, but it was really accelerated by COVID.
So we'll use two letters now. What about AI? A lot of physicians, I hang out at the lounge at the hospital, I see people in the emergency room, we walk around, and everybody sort of tries to think about whether their job is in jeopardy or not. You know, you look at the radiologists, they're quite concerned, because a lot of studies show that looking at x-rays with an AI device really is as good or better than the radiologist. Obviously, there are different things radiologists do procedure-wise with their hands, and that we have to open up arteries and do different things, open up different ducts and different tubes, basically. But clearly, the idea of AI with this whole process, do you think there'll be one day that, I mean, maybe my job, probably, your job might one day be done by not a person?
So let me talk about AI for a minute. I'm not going to talk politics, I promise I won't, but I am a labor Democrat to the tips of my toes. Everything in life for us was always about jobs. Most important thing, people got to work. AI is going to take out a lot of jobs. I don't know about Walmart and all the other places, but in medicine, you're going to lose ER doctors for
But
sure.
tell us why. I mean, why would
Because all you have to do is enter the data. So you put in 6'2", 140 pounds, palpitations, prior history of asthma, and all of a sudden you're going to get a differential diagnosis in seconds. That's incredible, and it's going to tell you which way to go with the care, because the ability to discern is immense. So guys in the emergency room are going to lose their jobs. I have kids coming to me for letters of recommendation. I say, listen, time out. You better think about this. You sure you want to do emergency room medicine? Radiology, you've already hit on that. I mean, we got AI now, and the diagnosis are spot on. I mean, it's unbelievable. So I think we're going to lose a lot of jobs in medicine. It's coming. Am I going to lose? Is a robot going to be able to do a hernia by itself? No, I don't think so. Not in my lifetime. But it's going to come to that eventually. It's going to be a shrinking pool of people doing medicine because you don't need them all.
Interesting.
Yeah, it's scary for a lot of guys and girls. I mean, it's just scary.
But it's also scary for our audience. If you think about it, I mean, the idea of going into an emergency room and not seeing a doctor but seeing a screen, as you mentioned, COVID really pushed things forward. There's still so many specialties like psychiatry and others that do everything through telemedicine.
That's right.
And I still think, and as I'm rubbing my nose, walking into someone's room or seeing a patient and smelling the situation is something that's beyond the point of anyone could know. You could basically tell, I'm sure of so many of our viewers, you can go into someone's home and tell how they are just based on their hygiene, the smell of the house. It wouldn't take 2 seconds. You go into a school, you see how people look, their body odor and things like that. The idea of what we can tell, and that's just one sense that we have. Of course, there's touch, there's sight, there's hearing, there's just some the mild groan of a patient. How they look really makes a big difference. So I still haven't gotten to the point where we're not going to be needed, but it's hard for me, even and not only as a physician, but as a patient, to think how hard it would be to walk into a place where there are, I'm not sure who would actually be there, but there'd be people there who would sort of funnel me into a different way of figuring it out. So,
but you see, we're over 50, so the kids, the people coming up, patients and doctors who are under 50, they look at this entirely differently. And insofar as AI and taking care of patients, we sort of gave up a lot of medicine to doctor extenders. They have nurse practitioners, they have nurse anesthetists, because they all want to beat the cost. It's always been about cost. And I think that's inured people to accepting, they don't see the doctor anymore. They see a nurse practitioner, they see a nurse anesthetist. It's happened. So to make that transition from that mindset to AI and robots is going to be so big. It would be for you and me, but not for that generation. It's a big difference.
It's like video games, right?
Yeah, exactly.
So we have only a few seconds left. Tell us anything interesting, other things that are interesting in pediatrics. You mentioned something that was that before we started, that I think whichever disorder you mentioned, I forgot what there were a few you did, that somehow when it's cold, there's more common. So, and we talked about the testicular issue. So tell us a little bit about what mom and dad, actually here's a different way I'll phrase it. What should mom and dad worry about when a kid to make them go to the doctor, the pediatrician, and or the pediatric surgeon? What gives you that concern?
All kids want to do is run around and play. When they're not running around and playing and they're telling their mother or father they're hurting. And nobody knows a kid better than a mother. When a kid brings the bicycle up the porch, when the kid goes up the stairs, the mothers know exactly what kind of a day they had. It's intuitive. Mothers know everything. And all you have to do is listen to the mothers, and they'll give the diagnosis. I tell the residents all the time, if somebody brings a kid to the emergency room at 10 o'clock at night, you better listen to them, because there's something going on. These mothers aren't coming here at 10 o'clock at night for nothing. So I implore people, listen to the mothers, and they'll tell you the diagnosis. You don't have to be Louis Pasteur. Listen to the mothers. They'll tell you the diagnosis. And if the kid is hurting and he's not wanting to play around and be himself, that's a telltale sign.
And I think that's just such wonderful advice. Sometimes when people come to the doctor's office, they're waiting, half hour, an hour to see the physician or whoever the healthcare provider is there. For them to take time out of their day, and today was a beautiful day in New York.
Right.
So the idea that someone was sitting in my office for whatever period of time, half hour, 45 minutes, to see me, they're not doing this because they have nothing else to do.
That's right.
And you really have to believe people.
Yeah.
Not everybody, no one has, very few people have ulterior motives. There are very little things that could happen that will help you going to the doctor, other than getting well, of course. So there's the secondary gain, I think, is something that has just gotten people too jaded over the years.
But nobody knows a kid like a mother.
Right.
And if she says there's a problem, better listen to her.
Dr. Gilchrist, Brian, it was a pleasure to have you here.
Good to see you.
And if there's any better advice that anybody could say to anybody, is listen to your mother.
Right.
Listen to the mothers of the world. The show is going to be playing over the next few months getting towards Mother's Day. So always take advantage of that. And as a physician in any profession you're in, always listen to the family, always listen to the person. Nobody wants to waste their time, and without you really knowing that there's a problem there. You always have to believe them. So believe our patients and believe in ourselves, and thank you so much. Have a great night, everyone.